Okay, so it looks like the people joining it's slowing down a little bit. So I can just start with some introductions and some like preliminary information, and then that'll give people some more time if they're running a little late. Um, so I just want to do a quick overview of some housekeeping information. So some of the features you might want to use during this webinar. So if you have any comments, questions, or concerns about technical issues or something like that, you can go ahead and enter that in the chat box, and I can try to resolve those as best as I can, like during the presentation. And then when using the chat box, you can select if you want to send your message to panelists only or to all attendees. But I do ask if you have a question for the presenter about their presentation content, you can put that in the Q&A box that's separate from the chat. I don't know if you can tell the difference, like the chat box is one with just one speech bubble, then Q&A has two. And that will help us just be able to find your questions, because sometimes they get lost in the chat because people, are typing a lot, so that'll help. And then another thing that many people ask is, yes, we will be recording the webinar. The recording will be available on the CADCA website, as well as links to slides and to the article being discussed. I will also be sending out an email to everybody who attended with this information, so don't need to worry about that. You will have that. We also provide a letter of participation to attendees if you do want that for credit for some reason. And I'll give you guys some more information about that at the end of the presentation, but basically you'll just have to fill out our evaluation, and then there will be a link to that letter of participation. So with that, I'm going to get started. So I'd like to welcome everybody to the latest installment of CADCA's Research into Action webinar series. I'm Jacqueline Brogdon. I'm a member of CADCA's evaluation research team. So if you haven't previously participated in one of our webinars, the purpose of this series is to introduce coalition members and substance misuse preventionists to current and relevant research being conducted in the substance use and community coalition fields. I'm joined for this installment by Dr. Jessica Cance, and she'll present on her and her colleagues' article examining the relationship between social connection and opioid misuse, a systematic review. And this was published in Substance Use and Misuse, that journal, in 2021. She's going to be discussing some components of social connection, the complex associations between social connection and opioid misuse, and some potential implications for prevention and treatment programs. So now if you want to go to the next slide, Dr. Cance, I'd like to introduce our presenter. So Dr. Cance is a senior research public health analyst at RTI International, which is a nonprofit research institute. She works in the Substance Use Prevention Evaluation Research Program, and she has 20 years of research and practice experience focused on addressing substance misuse from a public health perspective. She's led and contributed to epidemiological research, program implementation and evaluation projects, and coalition building supported by state, federal, and foundation funding. She also received her Master's of Public Health from Emory University and her PhD from University of North Carolina, Chapel Hill. So now I'm going to turn it over to Dr. Cance to discuss her work.
All of the fun of Zoom. Hi, everyone, and thanks for attending today. And thank you, Jackie, for your introduction, and many thanks to you and CADCA for inviting me to talk. So again, my presentation today is based on a systematic review of the literature that my team and I published last summer in the Journal of Substance Use and Misuse. And this work was supported by the National Institute on Drug Abuse, or NIDA, as part of the HEAL Prevention Initiative. And so before diving into the results of our paper, I wanted to first give an overview of NIDA's HEAL Prevention Initiative. And so the HEAL Prevention Initiative is a growing portfolio of research projects that are funded by NIDA to advance the science and practice of preventing opioids and other substance misuse and disorder. And so to date, of the approximately $60 million that's been allocated to the HEAL Prevention Initiative, about 90% funds the HEAL Prevention Cooperative, which I'll describe in more detail shortly. And so there are 4 strategic areas of the HEAL Prevention Initiative. First is risk identification, which includes studies that aim to understand who is most likely to engage in the misuse of opioids or other substances, and who is most likely to develop opioid or other substance use disorder. The second, social determinants, health equities, and policy, includes research designed to identify and address the social determinants impacting opioid misuse and opioid use disorder. Intervention development is the third, which is focused on establishing and expanding the evidence base for programs designed to prevent opioid misuse and opioid use disorder. And last, and most relevant to everyone here today, is dissemination, implementation, scale up, and sustainment. So the HEAL Prevention Initiative is focused on increasing the likelihood that evidence-based research and interventions are disseminated to communities both efficiently and effectively. Doing double screens. So the HEAL Prevention Cooperative, or HPC, is focused on developing and testing interventions that are designed to prevent opioid misuse or the escalation to opioid use disorder among those ages 15 to 30. And the HPC consists of 10 research projects located throughout the United States, and RTI International, my organization, is the coordinating center for the HPC. And the coordinating center is led by Drs. Philip Graham and Ty Breidenauer. So here I've listed just some of the specific goals of our cooperative. So the 10 research projects are really the heart of this, and they're implementing the prevention interventions across the behavioral health continuum, from universal to indicated prevention. And our coordinating center is focused on increasing collaboration across the HPC, including helping to develop common measures across the 10 research projects. And this will allow us to actually pool the data across all these 10 studies to learn more about the risk and protective factors. We're also learning about the costs, barriers, and facilitators to implementing these programs. And of course, all of this has been occurring amidst the backdrop of the COVID-19 pandemic. And so we're also working to understand some of those lessons that are learned from adapting and implementing prevention during this complicated time. And so as part of this overarching goal to better understand risk and protective factors associated with opioid misuse, our team in the coordinating center was tasked with conducting the systematic literature review that I'm going to present today. And so I want to begin broadly by discussing social determinants of health. So the most common definition of social determinants of health comes from the World Health Organization, or WHO. And the WHO defines social determinants of health as the conditions in which people are born, grow, live, work, and age. And these determinants include access to quality education, access to quality healthcare, economic stability, neighborhood and built environment factors, and finally, relevant to our discussion today, social and community contextual factors. And so in 2020, NIDA published a review article emphasizing the need to address the opioid crisis from a public health perspective. And this call to action included a need to shift from treatment of opioid use disorder and prevention of overdose deaths towards prevention strategies and improving our understanding of the underlying risk and protective factors associated with opioid misuse. So really starting to move upstream to figure out how we can prevent opioid use disorder. And so the article is laid out in 4 themes. And the first of those themes is a need to attend to the social determinants and the social context of opioid use. And so within this theme were these 4 specific areas of focus. And as you can see, our systematic review addresses this second area of opportunity to understand the role of social context in relation to engagement and prevention and the role of social supports. And so our goal with this review was to try and start disentangling our understanding of the role of social connection as it relates to opioid misuse and opioid use disorder. And so we have to start with, what is social connection? We know what opioid misuse is. We know what opioid use disorder is. But how do we determine what is social connection? And so, speaking broadly, social connection conceptualizes a subjective experience and the salience or the value of belongingness that individuals feel at an interpersonal level, community level, and society level. And so we know what it looks like when it's good, right? When healthy social connections are cultivated, research suggests that individuals are more likely to enjoy longer, happier, and more prosperous lives. So the more individuals connect with other people, the more they trust them. Greater trust leads to increased collaboration towards shared goals, which furthers our social development at large. But then how do we actually take that and operationalize it in our research and practice? And so one of the big challenges that we face is that existing literature lacks consensus in defining what is social connection. So when we think about it from the work that we all do, what item do you put on a survey to get at whether or not somebody has social connection? So researchers tend to either use the term social connection as this umbrella term that includes social engagement, social networks, isolation or loneliness, or they focus on just one of these areas. And so systematic reviews, like what our team did, are an important tool in social science because we look across a large number of studies to detect themes. And so it's important to note what this review included and what it did not. So when I start presenting the results, we have a better understanding of what this is and what it isn't. So first, we only included original research that was published between January of 1990 and March of 2020. So right here, we can note we actually stopped our literature review before COVID hit. So we know that these past 2 years have really changed things quite a bit. We also limited our search to articles that were based on quantitative or survey data so that we could actually measure that quantitative association. Could we tell if it was statistically related or not? And we also limited to studies that were based on populations living in the United States, because we know both social connection and the opioid crisis look very different in the United States compared with other countries. Now, we worked with our library services department to pull what could be any article that may be relevant in this area. So we had a complicated Boolean search that covered all sorts of different measures of social connection, also all different ways that researchers could be describing opioid misuse. So that included different types of opioids, different populations, talking about addiction versus treatment versus recovery. All of that was included. And so what we came up with was, for our start point, was nearly 1,300 publications. And so our team started there, and we reviewed the title and the abstract of every one of those 1,300 publications. And our team agreed about 90% of the time as to whether or not we should include it in our research. So then we moved to the next stage, which is of those, about 154 studies that we said, we think these might be really important. We then read every single one of those articles and decided again, does this fit with what we want to look at in our review? In this case, our agreement was a little bit lower. It was about 70% on the first try. And that was in part because we had to keep coming back to this question, is this social connection or not? Is this really specifically looking at opioids, or is it broader for other substances? And so most of the studies that we excluded at this full text stage were due to that second piece, what we call ineligible outcome. So specifically, these studies measured opioid misuse, but they actually combined that measure with the misuse of other substances. So for example, a lot of the research that's been done with adolescents often combined prescription opioid misuse with the misuse of prescription stimulants and other substances. And so for us, we were really interested in social connection and opioids. So we excluded those studies if we weren't able to actually see the difference between those two variables. We also excluded several studies because the researchers measured opioid misuse and they measured social connection, but they actually didn't look at the association between the two. And so this is another possibility of people have the data, but they might not actually be looking at these two variables together. And so our final review, what I'm going to be presenting today, included 29 studies. And so this was 26 peer-reviewed publications and 3 dissertations. Okay, so our first step, once we had these 29 studies, was to look at the characteristics of the studies themselves. And so unfortunately, we saw that there were a number of limitations within these 29 studies that need to be considered before I present the findings. So again, keeping it all in perspective. And so first and most importantly, is that most of the studies that were in our review were considered to be at high risk of bias, meaning that there was some sort of uniqueness to this study that made it different and not as able to be replicable in other settings. And so the most common limitation was sampling bias. And so what this means is that a lot of these studies relied on small convenience samples. So it would be, we interviewed 250 people who were at one substance use disorder treatment facility in a very specific location. And so the challenge with that is we don't know if you expanded to 2 treatment facilities in that specific location, would you have gotten different results? If you were looking at a substance use disorder treatment facility halfway around the country, would you have different results? And then, of course, as we're thinking about prevention, if you would have done this research in a school, would you have gotten different results? So we know that there is some sampling bias in here. And to that second point, thinking about prevention, the Surgeon General's report Facing Addiction in America, which was published in 2016, highlighted research showing that social connection is associated with a decreased likelihood of substance use among adolescents and young adults. However, nearly all of the studies that were in our review were with adult samples. So while we know quite a bit about social connection and substance use broadly, the literature on social connection and opioid misuse has been predominantly limited to adults. And with few exceptions, when we looked at the characteristics of the participants who were in these study samples were overrepresented by white males. And none of the research dove in and looked at the potential moderating roles of gender or race ethnicity. So even those studies that included men and women or had multiple races or ethnicities represented, they didn't actually look to see, does the relationship between social connection and opioid misuse vary based on those characteristics? And finally, one of the biggest challenges in everything that I'm presenting is that most of the research has been cross-sectional in design. So we're not able to say, is it that social connection leads to either increases or decreases in opioid misuse, or is it opioid misuse that leads to increases or decreases in social connection? So most of what I'm presenting today is that snapshot in time type of research. Okay, so as I alluded to towards the beginning of what is social connection, we also found significant variability in measurement in all of these studies, both in how researchers operationalize social connection, but also how they assessed opioid misuse. So across these 29 studies, there were no two studies that used the same measure of social connection or even the same construct and a measure of opioid misuse. So part of our challenge in trying to summarize and look at the themes across the literature was, where do we even start to try and organize this? And so we use the social ecological model, or SEM, as a guiding framework to be able to review the findings because there was so much variability across these studies. And so the social ecological model is a conceptual framework that was adapted in the late 1980s by the Centers for Disease Control and Prevention to better understand the multidimensional factors that influence health behavior like opioid misuse. And so at the start, at the center of these concentric circles, is intrapersonal factors. And so these are the internal characteristics of the individual of focus. And so in this case, this would include beliefs that exist within the individual, such as perceived loneliness, perceived rejection, and perceptions of social isolation. The next level, interpersonal measures of social connection, are factors that are associated with relationships between the individual and their family or friends. And so this includes measures like perceived social support, quality and content or structure of your social networks, connections to family or significant others, and connections to pro-social agents such as teachers or caseworkers. And then these last two levels, organizational and community measures of social connection, can be thought of as factors that are associated with relationships between the individual and organizations, or perceptions and experiences within individuals' communities. And so this starts getting at things like participation in school activities, religious service attendance, social disorganization, and social capital. And so one of the benefits of thinking about social connection within the social ecological model is that the SEM also proposes that behavior is impacted by all levels of influence. So it's not just one type of social connection that may influence opioid misuse. It varies from the intrapersonal to the societal, and that the effectiveness of our prevention programs is significantly enhanced when we coordinate interventions that are targeting multiple levels. So, for example, changes in community level social capital will create change in individual level beliefs, such as perceived isolation. And we know that changes at the individual level are essential for then moving up and changing our organizations and communities. Okay, I see that there's a couple things in the chat. So I think right now there are no questions, but I just wanted to pause. Is everybody good before we move forward?
Yeah, and if you guys have questions, please put those in the Q&A box and we'll be able to answer those at the end.
Great. Okay, so now what you're all here for, we're going to dive into the results. Okay, so first, looking at the intrapersonal level, we saw that 5 of the 29 studies included intrapersonal level factors. And again, these were things like perceived social isolation, perceived loneliness, and rejection from friends. So first off, notice that when we're talking about intrapersonal level, most of the research looked at the negative. So it wasn't about, do you have protective social connection, but it was really about looking at this from a risk perspective and a deficits-based perspective. Overall, amongst these 5 studies, there was limited to no association between these intrapersonal measures of social connection and opioid misuse. So we really didn't see a lot happening when we looked at these types of measures. So most of the studies in our review, 20 of the 29, included a measure of interpersonal social connection. And so these were things, again, like the behaviors and attitudes of a person's social network, perceptions of social support, family functioning, and student-teacher relationships are all examples of what was measured here. And what was interesting with this level is that we found both social connection to be positively and negatively associated with opioid misuse. So it was found to be a risk factor and a protective factor. So in line with social interactionist theories, which conceptualize social connection as this necessary function to help individuals develop their identity, we found that social network characteristics were associated with opioid misuse. So, for example, 3 studies that were conducted with youth and young adults experiencing homelessness found that a higher number of substance-using peers or ties within their network was associated with a greater likelihood of lifetime or past month heroin use. So those connections that actually help you to understand the norms within that interpersonal level were associated with higher risk. Now, in contrast, when significant, we saw that perceived social support and connections with pro-social agents were actually protective of opioid misuse. And so this is aligned with the theories that social support may actually be a buffer for stressful events. And so, for example, one of the studies found that the relationship between adverse childhood events and prescription opioid misuse was lower among adolescents who felt they had a close relationship to their teacher. So we actually see that social support in this case lowers the likelihood that an individual would engage in opioid misuse. Okay, and so then finally, we looked at studies looking at social connection at an organizational or community level. So first off, generally studies that used participation in community level events as a proxy didn't find associations with opioid misuse. So instead of looking at, social disorganization or social capital, they used proxies like religious service attendance or engagement in school-based activities. And so the one exception to this was that there was a study with older adults that found that frequent religious service attendance was negatively associated with prescription opioid misuse. But overall, we didn't see that those proxy measures were really tapping into what we're thinking about when we think about community connection. Now, in contrast, we saw that social capital was significantly associated, but it was found to be both positively and negatively associated with opioid misuse. So in other words, social capital was found to be both a protective factor and a risk factor. This was surprising to us. And so we looked deeper at the studies, and we actually think that it may be for similar reasons as the contradiction that we saw at the interpersonal level. So, for example, one study found that adolescents who were living in neighborhoods with high social disorganization, low social capital, were more likely to have misused prescription opioids. But among that same group, those who had higher levels of social participation in these disorganized neighborhoods were more likely to have engaged in opioid misuse. So it's not just about participating in your community and feeling connected, but feeling connected to a community that has norms against misusing opioids. So it really gets more nuanced. Okay, and so just like there were limitations in the studies that we reviewed, we have limitations and considerations in our review that we did. So first, we did make the decision to limit the review to the United States, and we know that there are going to be differences. Second, though, more importantly, we made the decision to exclude qualitative research. And while this was done for methodological reasons so that we could look across themes, we really think that this is going to be an important next step, because the qualitative research really focuses on a variety of social connectedness constructs. And so this includes those social determinants of health, of the influence of community and economic variables, including things like the effects of stigma and social norms. And not just if there's a presence of a romantic partner or the number of friends, but really diving into the quality of those romantic, familial friendship relationships. And most importantly, this qualitative data really places a greater emphasis on contextualizing the experiences of marginalized communities. And so we know that this qualitative research really supports the need for additional quantitative research so that we can actually test whether or not the social ecological model and that interplay between multiple constructs of social connection really holds true once we look at a large number of people. Okay, so, and I'm purposely leaving lots of time for questions because I want to hear everybody's thoughts. So overall, the findings from our systematic review highlight the importance of both disentangling this umbrella concept of social connection and analytically assessing the interactions between these constructs. And so then what can we do? How do we actually translate this into practice? And so again, keep coming back to this. It's really important for us to be intentional about what we mean when we say we want to improve social connection. So our review confirmed that social connection is a very broad concept that can be both a protective factor and a risk factor for opioid misuse. So when we're developing our logic models and thinking about our activities and how we want to prevent opioid misuse, we need to be thinking about what is the actual component of social connection that we want to focus on, and how are we going to make sure that we do that in a way that's intentional, that creates a protective factor rather than accidentally creating a risk factor. And so I know this is not surprising to anyone today. We know that what's most important is to create spaces for meaningful and healthy relationships. And so encouraging adolescents and young adults to spend more time with friends could lead to more opioid misuse if we don't also consider the behaviors of those friends. So it's important to be having conversations about who are you friends with? Who are you, getting your information from? And how can we create connections with people who we know really are looking out for you to have a healthy life and well-being? And so related to this, I think something that is on a lot of our minds is we need to continue to try and disentangle the impact of participation in social media. So we know that the pandemic led to many young people and older adults too, to engage more online and in social media. However, none of the studies in our review measured social connection as social media engagement. And so given the contradictory findings of social networks versus social support, we would expect similar contradictions with social media engagement. And so we need to be thinking about, when we are talking about the role of social media among adolescents and young adults, we don't want to be measuring it as just how many hours did you spend a day on social media, but what were you really doing? And again, what's the context of that engagement? What are the types of pages? Are you just cursory scrolling through, or are you really trying to have a meaningful conversation with people? We would expect from our review that those things are going to differ a lot. And then finally, while only a couple studies look specifically at civic and community engagement, we saw that community disorganization was a risk factor for opioid misuse. And so the work that all of you do to create, increase these connections across community really matters. And we know that increasing opportunities for pro-social engagement in the community matters. And so I want to end again with plenty of time for questions. And if you have any questions for me that I'm unable to answer today, or as you think about it and have a chance to read the article, please reach out and I'd be happy to have a discussion. Okay, Jackie.
Okay, so thank you, first of all, for that presentation. It was super interesting. This is always something that I'm really interested to read about and hear about. And so CADCA is first going to ask Dr. Cance some questions of our own, and then we're going to turn it over to participants to ask their own questions. So if you have a question for Dr. Cance, you can go ahead and put that in the Q&A box if you haven't already. And then I'm going to start the Q&A session with some of these questions. So in your presentation, you discussed the 4 levels of relationships, so that intrapersonal, interpersonal, organizational, and community. Which do you think is the most neglected that maybe coalitions could be focusing more on?
And so I think at this point, the most neglected is community, specifically with opioid misuse. And so while our review found only a handful of studies that had looked at community level social connection, we know that there's this rich body of work that supports community connections as a social determinant of health. And so getting to have this question in advance, I dove in a little bit. And, a national study that was conducted by the Robert Wood Johnson Foundation found that less than 20% of adults feel a strong emotional connection to their community, and less than 10% feel a strong sense of membership in their community. And more importantly, that survey was conducted in 2018, prior to the pandemic, which we know has dramatically shifted our perceptions of community connectedness. And so I think we need to better understand community and how we can actually be improving that.
Yeah, so a follow-up question would be, do you have any tips or tricks for coalitions on how to improve connection at that community level?
Yeah, and I think it seems counterintuitive, but facilitating opportunities at the community level requires really thinking local. So we can't think let's increase connection across all of Austin where I am. It needs to be in my zip code, and maybe even less so in my neighborhood within my zip code. And so this can be things like sponsoring walking groups or other outside fitness classes in the area, supporting park cleanups or other volunteer activities, hosting or co-sponsoring neighborhood block parties, and also making sure that we're encouraging connections across organizations. So making sure that our schools are talking with our local businesses and that we're actually facilitating those relationships. So really thinking about our coalitions as being central to those connection opportunities.
I think those are great tips for our coalitions, and I'm sure they might have some follow-up questions about that in the Q&A. So you mentioned that one limitation of the study was that the studies looked mostly at men. How do you suspect that the results may differ for women?
Yeah, so I think it's important that we include this as a potential limitation, because we know there's gender differences in substance use and misuse, and there's also gender differences in experiences with social connections. So, I can't say for sure, but I suspect we would have seen more significant associations between social connection and opioid misuse, both as a risk and a protective factor, if we had greater representation of females in the study. Just because research has shown that social embeddedness tends to be stronger for women, and we tend to see stronger transmission of norms. So you have a high quality social network, But again, if it's encouraging opioid misuse, you're going to have a higher likelihood of opioid misuse. So I think we might have actually seen more significant associations beyond the 20 of the 29 studies that we had.
Yeah, it's definitely interesting, and possibly, some like food for thought for like future, research opportunities and things like that. And our last question is, so one of the initiatives of the HEAL initiative is to break silos in prevention. What are some of the silos that you see and how might coalitions work to break these?
Yeah, so, often in prevention research, we build relationships based on the populations and the settings we serve. So, for example, prevention scientists who work in schools tend to collaborate more with other school-based researchers, and preventionists who work in clinical settings like doctors' offices tend to have stronger collaborations. And we also typically silo based on the age of our participants, right? So people who work with youth tend to really go to youth conferences and talk with each other. And same thing, people who work with adults tend to really see that as different. So the HPC is unique because we have research across all of those domains. Again, it's ages 15 to 30. And we've got people working in juvenile justice settings, in schools, in clinics. And so we're going to be able to look at the commonalities across all of these. So for example, one thing that I mentioned early is that we're looking at the commonalities of how the pandemic has impacted the implementation of interventions and the lessons we can learn across all of those different studies. So it's not just how hard was it to do research in schools, but how hard was it to do research overall? And what are the opportunities that we learned during this time period? And then with our community stakeholder board, which is part of the HEAL Prevention Collaborative as well, we're working to break down that divide between researchers and practitioners. So it's really making sure that there's this two-way communication between researchers developing the evidence base and the practitioners who are implementing the evidence-based programs. And so I would encourage everyone who's working in coalitions to really be thinking about how you can be engaging researchers in your area. So it may be the university down the road, it may be, an academic medical center, and trying to see how can we make sure that we speed up that research to practice pipeline. We know that we need to have very controlled studies to be able to determine that something is evidence-based. But how can we be having conversations while that research is occurring to make sure that it's able to be disseminated quickly, that we can scale up once we get beyond these tightly controlled randomized controlled trials?
Okay, thank you. And I just looked in the Q&A, and we have a lot of good questions. A lot of them are kind of complicated, so I'm going to try my best to like word them in like a concise way. But so one of the things that someone is asking about is what you might recommend for future survey research on this topic for substance misuse among adolescents and young adults. So maybe what types of social connection would you recommend looking at if you were looking at a younger population?
Yeah, so again, I think it depends on what your target is, Parissa. I'm not meaning to put it back on you. But I think if we're looking at interpersonal level, it is important to look at measures of, what are the norms of your friends, which sort of gets at that social network type of measure. But then also your perceived social support and really thinking outside of just the friend group. So what's your perceptions of social support amongst your friends, your family? And again, like the one study that we looked at, it was your teacher. How connected do you feel to a specific individual? And so it starts to get at the substance using peers piece, but also how closely connected you feel. And again, if we're looking at the larger community level, there's some really great scales looking at social capital and community connectedness, and I'd be happy to share some of those with you. I think trying to tap into how engaged do you feel, does that individual feel as part of that community? And I would say those are some of the key measures.
Okay. Another question someone asked, are you aware of any youth development or engagement programs that are specifically designed for youth who have started using substances, but maybe have not yet developed a substance use disorder? And maybe the answer is that you don't know, and like maybe you can work, whoever this was that submitted it can email after, but yeah.
Yeah, so one of the exciting pieces of the Heal Prevention Collaborative is that there are a number of the studies, and actually most of the studies are focused on this population because we know it's really a challenge. We either have universal prevention, which is meant for those individuals who haven't engaged, or we have on the extreme end indicated or early identification programs where somebody might actually be really close to developing an opioid use disorder. And so there has been a real gap in particularly selective programs, and that's sort of universal to selective. And so, it is really important as we look at this systematic review to be thinking, like you said, youth engagement efforts, where we need to really work to make sure that people feel connected to their community in a way that isn't leaning on connections to individuals who are already using with them. So can we be doing things, like I said, of volunteer opportunities, mentoring programs? We've seen that youth who mentor other youth do start to feel more of that meaningful connection to their community. And so really trying to stop that path once it's started. And that is a really important thing. Definitely follow up with me if you want to talk about very specific strategies. But yes, that is absolutely something that the Heal Prevention Collaborative is working towards.
Okay, and we have another question that I think is really interesting. It's about this person said that they work with a large Hispanic community population. And so something that they see is that families will maybe keep medication, like opioid medication, to bring back to their home country because it's more expensive there. Maybe you can't even access it. And so they're wondering what they can do to make a better connection to the community members to protect them at home in the US and then possibly abroad. And I know that your studies looked mostly at the US, but maybe in some of your other work, you might have thought about this before.
Yeah, and I think it's it's one of the big challenges when we're talking about prescription opioid misuse, because we start to have overlap in social determinants of health. So this is really getting at when you don't have access to quality healthcare, you get a prescription and it's, I'm going to save this because either I don't have access to this medication that I need, or it's really expensive or time consuming to be able to get to a clinician, get diagnosed, get the prescription, and then to throw it away really feels wasteful. And, I've heard that from community members for years. Like, why, if I've spent all this money to get this prescription, would I throw it away? Because I might need it down the line. I think what's really important is that we talk with community members from a data-driven approach and explain the most likely place that a youth is going to get opioids is from the medicine cabinet of family or friends. So we know that there is prescription opioid misuse, and the most likely place that they are getting those is from someone's medicine cabinet that had a legal prescription. And so really emphasizing that we need to make sure that we are not transmitting the norms, that it's okay to misuse opioids, but also making sure that they understand This is similar to where we talk about having access to lethal means for individuals who are at risk for suicide. We need to make sure that we are keeping things safe. So we talk a lot about locking up alcohol so that kids can't get access to it. So we need to be doing the same thing when it comes to prescription medication.
So this one isn't so much a question, but I just wanted to share something that Katrina had written. And so something that they were talking about was the depth of the social connections within, that drug using community. And so when people go into recovery, something that they struggle with, it seems, is that maybe some of those new friends that they're making, those connections aren't as strong. And so there's kind of that void of maybe they had those really deep connections with people, but those people are no longer, maybe, they're not really supportive in their recovery process. And so just thinking about deepening connections and creating healthier groups within that recovery community.
Absolutely. And, today we're focusing more on the prevention side, but there is so much on the theoretical basis of recovery capital. So similar to talking about social capital more broadly, recovery capital is a really important piece of whether or not individuals are able to maintain the level of recovery that they desire. And so a big piece of that is having those healthy relationships. And to your point, Katrina, having the availability of those individuals can really be a challenge. And so some of the things that are being worked on in recovery organizations are really trying to harness the power of social media. So do you actually have apps that are closed loop all other people who are in recovery? So you're not trying to seek them. It's okay, everyone who is part of this recovery community is able to engage each other in, sort of like a Facebook, but more of a closed loop way, so that you can try to continue those relationships. So it might not be the person who you sat next to when you were in treatment, but it's somebody else who has walked that same path that you have.
I think we'll take maybe one or two more questions. So someone asked about if you notice any difference in these studies between people who had sought mental health services for this substance use versus people who maybe were labeled by others as having substance use disorder.
Yeah, so unfortunately, there was not enough, again, consistency across studies. That was one of the things we were interested in. We were also interested in trying to see somebody who had a substance use disorder, or opioid use disorder in this case, and had not received treatment versus those who were in treatment. And unfortunately, we just couldn't get at that level of detail. Same thing, I saw a question about cultural differences, and again, there was not enough data and variability to be able to test that. So that's where I think the qualitative literature is going to help us so much more to really dig in and better understand what's going on here.
Okay, and then one last question. So is there research that you know of maybe for adolescents regarding social connections in the workplace?
That is a great question. I do not know of it specifically. I think, again, we have more of the volunteer literature, and then we have the workplace literature. So we should definitely connect afterwards, because I'd love to have a conversation and think about where we might be able to dive into that. Because again, like with all of this, if you're in a workplace that is actually encouraging interaction with older peers who may not be doing the things that we hope adolescents will do, we would expect that the workplace would actually be a negative influence versus having that community civic engagement, which we know is protective. So I think it could be complicated.
Yeah, that just reminded me of my first job in high school. I worked at a fast food restaurant, and
Yes.
there were many drugs being done there, both on and off the job, I will say. Definitely something I noticed. So I could see how, it could be, yeah, definitely a risk factor.
Yeah.
And so, yeah, so that's the end of our Q&A session. Of course, you can email Dr. Cance if you have any other questions. And I just want to reiterate, so these slides will be distributed to those who participated. We have your emails through Zoom. So I will be sending out an email that contains a short evaluation for the webinar, which will help you get that letter of participation. We'll include a link to the slides as well as the recording and the original journal article that this presentation was about. And yeah, you'll have all that information in the next few days. And we just want to thank Dr. Cance for the wonderful comprehensive presentation on her work and for her commitment to providing relevant and current material. And thank you all for your great questions, comments, insights, and we hope to see you at another one of our research and action webinars. And yeah, hope you all have a great day.
Thank you everyone for attending.
Okay, bye. Have a great day.